The Fellowship of the Great Physician welcomes you to House Call. Our hosts today are doctors of chiropractic, Dr. Gerald Lala and Dr. Richard Jensen, who is also a board-certified acupuncturist, practice independently in North Oaks, Minnesota. Let's join our hosts for today's program that will assist you in your quest for optimum health and well-being.
Welcome to House Call. I'm Dr. Gerald Lala.
And I'm Dr. Richard Jensen.
Wonderful to have you with us in this dimension of House Call. As the screen says there, acid reflux part 1, we could say you can eliminate, if you have acid reflux problems, you can eliminate it naturally. And so Dr. Jensen is going to start talking about acid reflux and what is it. So Dr. Jensen.
Thank you, Dr. Lala. Well, acid reflux is a condition of the stomach, as you can see there on the screen. It's a condition that results from excessive secretion of hydrochloric acid, which we will go into numerous reasons for that later in this series. Also, it's commonly referred to as dyspepsia, or that we just aren't having the digestion of the proteins in our body, which is normally used by pepsin. So then, Dr. Lala.
And
who does it affect?
Who does it affect? Hey, look at that, 40% of the adult population. Now let's look at some of the primary symptoms of dyspepsia or acid reflux. There they go, look at it up there. You don't have to have all of them, but you can have many of them. Heartburn, upset stomach, diarrhea, abdominal bloating, burping, irritable bowel syndrome, nausea, belching, constipation, cramping, abdominal cramping, and intestinal gas. What are some of the secondary results of acid reflux? Here we go: gastritis, inflammation of the stomach, peptic ulcers, gastric cancer. You keep having acid reflux and keep doing nothing about it or dumping in these drugs to try and mellow out those acids, and you'll end up with gastric cancer and certainly malnutrition, because if there's too much acidity in the stomach, then you are not going to digest your foods or absorb them correctly. So now Dr. Jensen is going to look at symptom differentiation of dyspepsia. Symptom differentiation of it, and he's going to talk. He's got an underline there for you, functional. It's important that you listen to him now.
Functional dyspepsia. So we're looking at a symptom differentiation here of dyspepsia. This is functional dyspepsia. It comes with heartburn, epigastric tenderness, and when we're looking at epigastric tenderness, we're looking at the area around the belly button where you're finding that. So if you're pressing in there, there's tenderness there. There's food repeating, so you're burping up your food, and you get to taste it again. How about abdominal distension? These people, they tend to have abdominal distension. There's a wonderful description that I've heard of this because it's so rampant in the United States from our diet that we hear foreign nations call us balloon people because of the distension that takes place in our intestinal tract. So let's go on from there. Belching would be another differentiation symptom, and nausea can also be that, where we're having trouble looking at food, actually. Then we have symptom differentiation. The symptoms of an ulcer rather than functional dyspepsia. Here we're looking at ulcers. They again have heartburn, again have epigastric tenderness, again have abdominal distension, and again have nausea. So this is differentiated in that you don't have the food repeating or the belching from that functional dyspepsia would have. Then, Dr. Lala, how about symptom differentiation for gastritis?
Thank you, Dr. Jensen. We'll leave that slide up there. What Dr. Jensen just did is he did a symptom differentiation between ulcers and dyspepsia. Now we're doing a symptom differentiation of gastritis. Now, before I do that, why would two doctors of chiropractic be interested in that? Well, certainly we take care of spines and strains and sprains and things like most chiropractors do, but we are more in a whole person perspective in that we're looking at the person in the whole, not just spine or structural wise, muscles, bones, and ligaments, but psychologically, spiritually, if that's what they want, and then biochemically. And many of the people that we see who have dyspepsia, gastritis, or ulcers have gone the orthodox medical route. They don't want to take any more drugs, they don't want to have surgery, or they don't want to have more surgery. They want to try something naturally, and what we're doing here is showing you how to do that. Now, let's look at differentiating. See, we talked, if you were in medical school or chiropractic school, they would call it differential diagnosis. So symptom differentiation of ulcers, the symptoms generally of ulcers are heartburn. See, some of these are similar to gastritis, all right, and dyspepsia, but heartburn, epigastric distress, and we push down on here, there's distress, abdominal distension, and nausea. So you can have gastritis symptoms and ulcer symptoms at the same time. Now, Dr. Jensen.
Another thing that you should also look at for differential diagnosis is that in heartburn, many times women, when we're talking about heart attacks, women many times their heart attacks can present as though it's heartburn, okay? Many times when men are having heart attacks, it's kind of a crushing chest feeling that you usually hear about, but women, many times it's in heartburn. Now this can have crossover too, so it's better for you to have it checked out because we don't want you to have a heart problem either. So this is about gastritis and more stomach problems, but also to have it differentiated from heart problems would be important stage for you as well if you have some of these things.
So what are some of the causes now?
Some of the causes
of dyspepsia or acid reflux.
Okay, let's come through these. And causes is Helicobacter pylori infection. So this is the type of infection that tends to make a gastric ulcer. Food intolerances can cause this as well. It's just that you have an intolerance to foods and therefore make it harder to digest. And so all these stomach acids have to be dumped in further, causing problems there. Spinal problems, so you're not having good nerve flow to these organs, so they're not functioning as well as they should be. How about the use of NSAIDs? So the use of particular drugs can cause problems with your digestion. Of course, that's the way of delivery that we're using, and so it's affecting that. And stress can also, we know that stress, it changes the relationship between your fight or flight nervous system, and therefore shuts down digestion and makes it harder to use there.
Good idea now to talk more specifically about the Helicobacter pylori.
Right, so let's go into Helicobacter pylori. It is a bacteria, and it increases the risk of non-ulcer dyspepsia. So it increases the risk of that. Usually we see Helicobacter pylori as a cause of ulcers. Here it also increases the risk of non-ulcer dyspepsia. Peptic or duodenal ulcers also have an increased risk. And acute or chronic gastritis can also be a risk there. It is a bacteria that 2/3 of the people worldwide are infected with, and infected people have an increased risk of non-ulcer dyspepsia, peptic and duodenal ulcers, and or acute or chronic gastritis. So where does Helicobacter pylori come from, Dr. Lala?
Hey, I'll tell you, it's got some sources. One is heredity. Secondly is oral transmission. It can be transmitted orally through kissing or through saliva, or coughing, sneezing, and it can be contaminated with food. One of the things that's really interesting to me is the number of people that we see for irritable bowel syndrome, gastritis, acid reflux. I cannot believe the number of those people who have been treated medically where the test has never been run. It's a very, very simple blood test, and it has not been run. It's incredible. And so H. pylori genotypes have been identified in families, leading researchers to theorize that it may be passed down from one generation to another, and as I said, it's found in the oral cavity of patients with gastritis. So how about some more on that, Dr. Jensen?
Thank you, Dr. Lala. Well, we have Helicobacter pylori infects the stomach, infects the human stomach. It has the ability to infect the human stomach. It can survive in the gastric environment of the stomach, and produces an enzyme, urase, that neutralizes gastric acid, which allows it to move into and infect the stomach and the small intestine. So it allows it to survive through that area as well. Now, it is spiral-shaped and giving it the ability to penetrate the protective mucus of the stomach and enter the gastric or duodenal epithelium, predisposing people to gastric and duodenal ulcers. So it allows it to just proliferate in there.
So the acid reflux or dyspepsia, ulcers or gastritis has to be treated different if it's H. pylori related, if they're an H. pylori positive, as a difference in H. pylori negative.
You're looking also from the point of view that this is a bacteria that's in there that's proliferating. It is something that is irritating the gastric lining, therefore making the stomach react in the only way that it can, and therefore it's different from having, say, something that your sensitivity to that's harder to digest. Mm-hmm. This is something that stays there and is and has the ability to stay there.
Yeah, we find that a lot of patients in the blood studies that we do, that they've been treated wrong. Mm-hmm. They've been treated by symptoms alone, or that those symptoms haven't even been differentiated. Oh, you've got this, here, take that.
Right.
How about that stomach mucosa? Can you discuss a little more about that?
Sure. Stomach mucosa. It's a thin layer of mucus that lines and protects the stomach from the acids normally secreted by the stomach. It's similar in viscosity to the mucus that runs out of our nose. And if it becomes less viscous or it becomes thin, too thin, the acid secretions of the stomach can cause stomach ulcers. Okay, so it starts to, in effect, digest the stomach. The H. pylori has the ability to drill holes in this lining of the stomach or the small intestine and take up residence in these areas, in the epithelium tissues. That's the covering. The inside covering of the stomach is epithelium tissue that comprise the stomach and small intestine walls. Dr. Lala, how about urase?
Urase, Dr. Jensen mentioned this compound. It's an enzyme. When you see the suffix on a word ASE, it means it's a form of an enzyme. So urase is an enzyme that weakens the stomach's mucosal lining. So when this enzyme is high, it's going to weaken that lining and predispose you to acid reflux, dyspepsia, ulcers, gastritis, and even gastric cancer. So it is an enzyme that weakens the stomach mucosal lining, allowing initial colonization or growth, proliferation in the stomach and small intestine. Once H. pylori is embedded in that epithelium, it's epithelial tissue, not connective tissue, it then produces chemicals that weaken the gastric and duodenal cells, the cells that are lying in the stomach and the duodenum, rendering them more susceptible to corrosive actions of gastric acid and another high acid called pepsin. So let's then talk about gastric acid. Okay, gastric acid. Often referred to as hydrochloric acid. It's secreted by the stomach when it's healthy. Normally it has an acid pH of between 3.0 and 3.5. Okay, now listen closely, because there's a difference between acid and alkaline in these different pHs, and there is a tremendous amount of misinformation out on the internet and out on television with these clowns, and I consider them to be unscientific clowns who are trying to sell these people these acid stomach nutrients. Okay, so Dr. Jensen, how about pepsin?
Thank you, Dr. Lala. Well, pepsin, it's a proteolytic enzyme, which means that it's an enzyme to break down protein. It's activated by gastric acid. So, proteolytic enzyme, again, is secreted and stored in an inactive form by the chief cells of the stomach. These are cells that are in the stomach wall that release them into the stomach. They are activated by the gastric acid. It's basically what happens is enzymes that are produced by our body tend to have the environment that they're made for to be active. And in this case, pepsin is active when we have an acid environment, which is created by the hydrochloric acid. So that gastric acid and pepsin can lead to the atrophy, to atrophy of that stomach lining, or create ulcers, in another word. How about diagnosing H. pylori, Dr. Lala?
Well, thank you, Dr. Jensen. We take a little break here before we get into this, and we realize that we're covering a great deal of information, and if you want the copies of the scripts that we use, you're more than welcome to call us, and we're happy to send them to you. When I talked about clowns on television, these so-called experts that are selling these acid problems, or acid nutrients, much of their information contains grains of truth. But when you put it under the light of scientific examination, it doesn't stand up. But they get away with it, just like they got away with coral calcium, pushing that for years and years. And then the scientists jumped on it. And then finally the FDA got involved in it. And you don't see any more of that now. But I will guarantee you this, what goes around comes around. And they'll be back selling coral calcium again, and it was junk. So diagnosing H. pylori. And how do I know it's junk? I'll tell you, come back with me here. I know it because when we do a blood study on people and check their calcium levels, and then they go on coral calcium or bone meal or dolomite, some of these very, very poor quality forms of calcium, and they're on it for 3 months and we retest it and it's not any better. Or when we have a bone density study of them or bone x-rays of them and we see osteopenia or osteoporosis, and we look at it again in 6 months and it's not improved, or even a year, which is plenty of time, it's telling us that those products are not working. But then when we go and look at their toxic metals, and we see that the toxic metals were maybe normal when we did the original blood or hair biopsy studies, and we check them 6 months later and they're high, where did they all of a sudden get these toxic metals from? Right out of the calcium, because it's the second most polluted form of food on the earth. Fish oil is the first. Calcium is the second. Where do they get it from? Ground. You going to tell me there's clean ground around on the planet Earth anymore? Forget it. Even where the organic gardens are, that's not pure ground anymore. If rain's coming down, there are all kinds of toxins, pesticides, and contaminants coming down out of the rain. So, as Dr. Jensen, now that I've got done epistolizing there, diagnosing H. pylori. Why not? The truth sets you free. The truth sets you free. Even the scriptures say that we're destroyed for a lack of knowledge. Keep throwing in those antacids. They'll do something for you for a while, and they'll just keep keeping that urease enzyme we've been talking about, and that H. pylori keeps growing and growing, and pretty soon you got an ulcer then. Now we have to use a bigger drug on you, don't we? And then when that doesn't work, pretty soon you got a hole in your stomach and your intestines, right? And then what does that hole turn into? Cancer.
One of the things that we're looking at, you mentioned antacids. One of the responses on this is most people take that when they're having heartburn. And it's because they're saying they have too much acid in their stomach. Well, what happens is when you put in an antacid, it neutralizes that acid in the stomach. Now the stomach has to respond by secreting more hydrochloric acid. And by doing that, it creates another problem, whereas you're getting more and more acid in there. And by treating it in that fashion, what happens is it wears out those cells that give off the hydrochloric acid, and therefore all of a sudden you're not giving off enough hydrochloric acid, and therefore is predisposing yourself towards food that's not being digested, which goes into food allergies and all these other symptoms, which I'm sure we'll get into later on.
That's right. Hey, if I have heartburn after I eat something, guess what? The first signals to me should be, I ate something and my body doesn't like it, so it's telling me it's no good for me. Well, Western healthcare says, Orthodox healthcare says, oh, put something on top of it. So I have a burnt cake inside of here. Now I'm going to put frosting on it. I still have the same problem because I'm treating the symptoms and not the cause. All right, how do we diagnose H. pylori? Through blood studies. We've mentioned that already. And then what does that blood study do? It's looking for the H. pylori IgE antibodies. It's a routine Orthodox medical test. Now, another test that is not often run, typically in an Orthodox medical facility, is the CO2 breath test. What is it? I'm going to read that to you so we don't make any mistake. The CO2 breath test measures the amount of carbon dioxide exhaled. Prior to the test, the patient is given a drink of either 13C or 14C labeled urea. That's not the stuff in the urine, all right? You're not drinking urine. H. pylori quickly, if there's H. pylori excessive levels, it quickly metabolizes the urea, and the labeled carbon is present in expired breath by exhalation. Then the H. pylori infection is much higherly diagnosed that way. Now, biopsy. Let's look at biopsy. What would the biopsy mean? Now, this is a fun test to go through. Thank God that we're not medical doctors and we don't have to recommend this test because you're out of the room when they're doing it, you know. It's easy to prescribe a test when you're not the one having to do it. All right, so biopsy. Tissue tests such as an upper esophageal duodenal endoscopy that may include analyzing affected tissues for the bacteria's enzyme, again, urase. Processing the tissue and observing for potential H. pylori growth or examining the tissue, of course, under microscope. Now, H. pylori stool analysis. H. pylori stool analysis looks for the presence of the H. pylori in the stools. And then another wonderful test, this is all complementary to one another, the organic acid analysis looks for markers or indicators that reflect intestinal dysbiosis or malfunction. Now, I want to go back up to the H. pylori stool analysis. A lot of people run off and they send a stool sample into their chiropractor, their nutritionist, or they send it off to some lab, you know, someplace in the United States or in Europe, and they're doing stool analysis. Is stool analysis legitimate? Sure, it's legitimate. Is it the whole picture? No, because it's telling me the end product that was going on in my digestive system, whereas like the organic acid analysis or the H. pylori test or the CO2 breath test, those are telling me what's going on now during digestion, not a reflection of post-digestion. So a lot of people will call us and they want to become patients and they say, look, I've had the stool analysis done and it says this, would you help me interpret it? And of course, you can call that company and they'll have somebody there, a consumer product representative, and I'll tell you what they'll do. They'll explain a little bit to you, but they'll always have some product to sell you. Now, that product may be good, but is it looking at you in a whole person perspective? No, it's not. So I can look at this one finger, I can look at it from the front and the back and the sides, I can look at it from the top. I've got a pretty good picture of this finger. I can take an x-ray of it, I got another dimension of it. I can take an MRI of it, I've got another dimension of it. I can take a blood test of it and see something in it, right? I can do that. I can do functional range of motion testing, orthopedic testing. I've got a picture of it. Does it tell me what the other fingers are in my hand? It does not. And you have more. You are more than just a finger. You are more than just a stomach. You are a very complex being, and so what's happening to people, they're being destroyed for a lack of knowledge because they are not wholly diagnosed. And Dr. Jensen, how about antibiotic therapy in H. pylori?
Thank you, Dr. Lala. Well, the body develops resistant strains to man-made medications, rendering drugs ineffective.
Are you telling me that I could take a drug and my body would say, oh, that's not all that good for me, so what I will do is make another?
Well, many times what happened was there was an abuse of the antibiotics.
Oh, no, there's no abuse of antibiotics in America.
And so what people did, and it wasn't entirely the doctor's fault.
Nope.
It's not entirely the patient's fault.
Because
but
the patients come into the medical doctor's office and demand those antibiotics.
Absolutely. And then sometimes what they'll do is they'll start them and not complete them. So they start and they start killing off the bacteria, but the strong ones are still there, but they're feeling so much better that they don't take the entire complement of antibiotics, and therefore now the strain that's left that's allowed to repopulate are the strong ones, the ones that are more resistant to it, and it gives them a chance to become more resistant. So now what we're finding here in these days is that as we have these superbugs that are being resistant to antibiotics, we've started to learn that lesson, and people are starting to be better at that and better educated in it, but we still have these superbugs. So what we're finding are resistance.
I know I went with a family member some time ago. She had some parathyroid surgery. And so when they went in to take out the staples on 2 different visits, and we got to know the surgeon really good. He's just a wonderful guy and a very capable surgeon. And on the second visit, they called and canceled and rescheduled it. Okay, so we went in a week later, and he looked terrible. The surgeon looked absolutely terrible. Surgeons, don't get much sunlight, And so, and we said, gee, you don't look very good. And he said, man, I have had the flu and an upper respiratory infection that's just a killer. And he was telling us he could finally dump his load on us, because nobody ever asks us how we are.
Surgeons
because
are people too, right?
They're people too,
Yes.
and good people too.
Yes, they are.
And I said, well, where'd you pick that up? And he said, look, I should have been a chiropractor. And I said, why? He said, at least you guys work, for the most part, in a healthy environment. He said, when you work in a hospital, you are working in a pest place. And he said, most of the people that are coming in there with infections, by the time they're hospitalized, they have superbugs. Mm-hmm. And he said, we're around them, and we're inhaling that stuff. No matter how much we wash our hands and try and protect ourselves and protect the patients, they're nailing us. And so this is a serious issue, just as much as a lot of times they'll come along and say, well, I want this antibiotic. And the doctor says, no, you don't need it. You'll fight it through. Well, I want this. No, you don't need it. And then they say, well, that's because this is a managed healthcare program and they don't want to spend the money for this prescription. No, that certainly could be possible. But no medical doctor in his right mind is not going to give you a drug if you need it. He's going to do that. She's going to do that. It isn't that the managed healthcare says you can't have that drug. They know. You realize how many people they see in a week, just like us, how many people we see in a week. And after a while, you just might learn what works and what doesn't work. And I don't believe there's a medical doctor on the face of the earth that doesn't want to do what's right for everybody that comes in their office. I just don't believe that. Dr. Jensen?
I agree.
Well, that's two of us. We're in agreement. And wherever two or more agree in his name, there'll be miracles.
Amen.
Okay.
So let's go back to the antibiotics therapy in H. pylori, where we have the drug and we have its resistance. So clarithromycin, what we find is an antibiotic that's used for its treatment, but there's 39% resistance against that drug. We also have a popular one, amoxicillin. Amoxicillin is used a great deal, but really the numbers are unknown at this time as to its resistance. We have metronidazole. I pronounced that metronidazole. That's another antibiotic. Tetracycline, which is a family of antibiotics that are used. And a combination of all of these we find have a resistance of 40% resistance. So it really is something that to be acknowledged in this. How about zinc carnosine, though, Dr. Lala? What about that one?
Zinc carnosine, a natural chemical that God has given us to use naturally against dyspepsia, acid reflux, and what we're going to do, it's a natural alternative to drug therapy. It's a chelated zinc sulfate and L-carnosine, more effective as a chelate than separate entities. All right, this has been part one of acid reflux, dealing with it naturally, getting rid of it naturally, treating it naturally. Hey, how about preventing acid reflux naturally? So what we're going to do in the next program is we're going to do preventing acid reflux naturally, part two. It's been great having you with us. Look forward to seeing you there because we're going to talk about all kinds of good stuff.
The Fellowship of the Great Physician, through its School of Health and Healing, provides classes each Thursday evening. The primary focus of these classes is biblically based spiritual health and healing, with a brief teaching on physical health and healing. There is no charge or registration fee for these classes, but a free will offering is received. For further information on the School of Health and Healing, class time and location, or the topics discussed on today's program, contact us at the Fellowship of the Great Physician in care of Dr. Lala or Dr. Jensen at 200 Village Center Drive, Suite 100, North Oaks, Minnesota, 55127, or telephone us at 651-484-8521. Thank you for joining us today.